Hi, good morning, everyone. We're going to get started so we stay on time today. So I just wanted to say good morning and thank you all for joining us for today's Grand Rounds. I have the pleasure of introducing our guest speaker, Dr. Ashish Kumar, who is a physician scientist in the Division of Bone Marrow Transplant and Immune Deficiency at the Cancer and Blood Disease Institute at Cincinnati Children's Hospital Medical Center. He is a professor of pediatrics at the University of Cincinnati College of Medicine and is also the director of the Multidisciplinary Histiocytosis Center. His current focus is on Langerhans cell histiocytosis and hemophagocytic lymphohistiocytosis, or HLH. Based on his research and experience, he has completely changed the approach to treatment of diseases like LCH, where he doesn't use chemotherapy at all. Instead, novel oral inhibitors have revolutionized the outcomes for patients with this condition. He also has a different way of diagnosing patients with HLH, which have resulted in improved outcomes. In his free time, he enjoys traveling, hiking, and cooking. He loves music, although the only instrument he can play is the air guitar. Please join us in welcoming Dr. Kumar.
All right. Can everybody hear me? Okay, this thing is on. All right. Thank you, Jamie, for keeping it short. And thanks, everybody, for coming in early in the morning. Let's see if I can, there we go. So, all right. So we're going to talk about HLH. It's a big, long word. We won't go into the details. Before we begin, just some disclosures. I have done some consulting work for Sobi. I also find lectures boring. So for those of you who are in the room, please feel free to raise your hand. Let's have a conversation rather than a monologue from me. All right. So HLH, some of you have heard this word. For those of you who have not, any people from cardiology, we're not talking about hypoplastic left heart. We're talking about hemophagocytic lymphohistiocytosis. It has 14 syllables. Keep that in mind. It'll come in handy later. But what is HLH? It is not one disease. So if you've been diagnosing HLH as one disease, I'm here to tell you I'm sorry, that's not the case. HLH is a phenomenon or a process. Think of it like shock. There are many different types of shock, many different reasons why a patient might experience shock. So there are many different diseases that can result in this phenomenon of HLH. There is one condition called primary HLH. Yes, there is that one disease. And that is caused by genetic mutations in the innate immune response. And we'll get to the details of that later. Everything that we think we know about HLH is based on now the study of primary HLH, but that is a minor component. Everything else, we still need a lot of learning to do. This is where the disease got its name. I'm going to try and find my laser pointer. This is the process of hemophagocytosis. So in this micrograph outlined by pointer is a large macrophage. This is in the bone marrow. And in the belly of this gluttonous macrophage, as my pathology colleagues will often say, this is the nucleus, but in the belly, you will find other cells that are being eaten up and destroyed. This is hemophagocytosis. And so what is this inflammatory process of HLH? It starts with disproportionate, or the better way to describe it is maladaptive activation of cytotoxic lymphocytes. So if you have a viral infection and the lymphocytes get activated, that is the normal, expected, proportionate response. When it is maladaptive, when it is not serving the purpose that you think it should, that is maladaptive activation. These activated lymphocytes then secrete cytokines. The most well-studied, the one that we care most about, is interferon gamma. When you have lots of interferon gamma circulating, it binds to its receptors, and the cells that have receptors for interferon gamma are macrophages. When they see interferon gamma, they become activated themselves. In their activated state, macrophages secrete additional cytokines listed here, and then they infiltrate the organs and result in symptoms that we have become familiar with: fever, cytopenias, inflammation of the liver, and a consumptive hypofibrinogenemia. And it is not a novel disease. This was first recognized in the year 1939 in this journal called The Lancet. You may have heard of it, describing a patient from 1929, so almost 100 years ago. And this patient had fever, wasting, splenic and hepatic enlargement, jaundice, purpura, anemia, leukopenia. The British need to learn how to spell properly, and phagocytosis of the red cells. A few years later, two children in the same family had the similar features of splenomegaly, fever, pancytopenia, hemophagocytosis. This was in the 50s when prednisone had not been identified or discovered yet. There was this thing called ACTH, and one of the infants had a transient response to ACTH. Just making sure everybody was listening. In the 1970s, this condition became to be recognized, and it got different names: virus-associated hemophagocytic syndrome, a very long word, FEL, but And then it wasn't until the 80s and 90s that this phrase of HLH was coined. The Histiocyte Society, the umbrella organization to which most of us belong, came together and created the first clinical trial in 1994 called HLH-94, where they came up with some guidelines on how to diagnose this entity. It wasn't until 99 that the first genetic mutation was identified. And by the way, this whole work was focused on primary genetic familial HLH. Nobody knew at that time what everything else is, okay? And then in 2004, they conducted the second clinical trial, and they called it HLH 2004. Very creative minds, but that's okay. And the eligibility criteria for that clinical trial, HLH 2004, became cemented as the definition and the description of HLH that we all use, okay? Most of you may be familiar with them, but in case you are not, we will review them very quickly. For that clinical trial, a patient was considered eligible for that trial if they met 5 of these 8 features: fever, splenomegaly, cytopenia affecting at least 2 lineages, elevated triglycerides, or reduced fibrinogen. Only one of them could be counted. Hemophagocytosis in the bone marrow, spleen, or lymph node, lower absent NK cell activity, elevated ferritin, elevated soluble CD25. In the absence of a malignancy, if a patient had these 5 features, they were eligible for that clinical trial based calling it HLH. Now, and that is the current dogma. We all still practice it this way, where if a patient meets 5 out of these 8 features, we call it HLH. Our adult colleagues have taken on the same features, but assigned a different weightage to some of them, and they call it the H score. The downside is that you need a calculator, or nowadays there's an app for that as well. You just plug in what features you have, and it spits out a score. And if a score is above 169, the probability of HLH is 92% or higher. The higher the score, the higher the probability. So once you've diagnosed the patient with HLH, we look for genetic mutations. If you find a mutation, we call it primary HLH. If you don't find it, we call it secondary HLH. The initial therapies recommended should be the same for everybody because it's a life-threatening condition: dexamethasone, etoposide. And if the patient has primary or genetic HLH, or they have recurrent HLH, the only treatment for that is bone marrow transplant. In case somebody was not paying attention, 2004 was more than 20 years ago. Let's think about what was happening in 2004. This was the world's most celebrated athlete. Some of you are too old to know who this is, but if anybody knows, can somebody shout it out? That's Lance Armstrong, winner of how many Tour de France? 7. How many does he currently have? 0. Okay, because we learned something about him. All right. In 2004, the hottest gadget that all of us wanted was this thing. Okay. In 2004, somebody thought this was the way to look. Yes, that is me. And no, that is not a wig. So if we have moved on from all of these, not because they're just old, yes, I am, but because we've learned that there are better ways. We have learned better. So what have we learned about HLH 2004 criteria and H score? Just a reminder, HLH 2004 was a clinical trial aimed at primary HLH. The so-called diagnostic criteria were the eligibility criteria for enrollment. They were never meant to be, and they still are not, the definition of HLH. And they were based on opinions. They were not based on evidence. The sensitivity and specificity of these criteria have never been prospectively tested. And when we have retrospectively tested them, do you know how good they are? They're not good at all. But you don't see anybody talking about that. There are no publications that state that because nobody likes to be told that, you know, what we've been doing is a little incorrect, or maybe we could do things better. And HLH 2004, the clinical trial was open to children only. Yet in today's world, there are more adults being diagnosed with HLH based on these criteria that have never been applied to adults in any prospective study. And the H score uses the same features. And there are several papers describing the validity of the H score. For every valid experiment, you need to have a gold standard. Do you know what the gold standard for the H score was? A physician's opinion that I said, so this patient has HLH. That is the gold standard that we started off with, okay? So what we have learned over the last 20 years is that these criteria are not diagnostic of a specific entity. They're just describing severe inflammation. They don't tell you what the inflammation is from. And so they do not distinguish HLH from other conditions that will fulfill these criteria. They are not specific enough. And there are some very non-specific features. The very first one is the phenomenon that lends the disease its name, hemophagocytosis. You can find it in many conditions. Every patient who has mononucleosis, if you were to do a bone marrow biopsy, their bone marrow is full of hemophagocytosis. Majority of patients with leukemia, lymphoma, sepsis, if you do a bone marrow biopsy, you will find they have hemophagocytosis. It is not specific to HLH. People believe a high ferritin is specific to HLH. It is not. There are many more papers describing the non-specific nature of ferritin, but they're not popular, unfortunately. There's a paper that says a ferritin above 10,000 has 98% specificity. Again, how do they define that? What was the definition of HLH? Meeting the 5 out of 8 criteria. So if you're starting with garbage in, you get garbage out. If you're starting with non-specificity as your starting point, if that's your gold standard, you're going to end up with non-specific features again. There are some other papers that think that these features, soluble IL-2 receptor, CXCL9, these are specific for HLH. They are not. They are just better markers of inflammation that involves cytotoxic T lymphocytes and interferon gamma. That does narrow it down, but it is not exclusive to HLH. And lastly, this one assay that is one of the 8 features, the NK cell cytotoxicity, it's completely useless. I have not run it in the last 15 years, ever since I identified that it's a useless assay. We have tried to get rid of it. Our hospital is the one that runs it. And physicians call us and saying, well, if you will not run it, who else should run it? And I keep telling them, why do you want to run it? Well, because it's included in those 5 out of 8 criteria. Unfortunately, that has become cemented in our brains. So I'll give you certain examples that led me down this path. These are real patients. 20-year-old male, develops fever, myalgia, seen in the emergency room several times. Eventually, somebody examines him properly and finds that he has hepatomegaly, splenomegaly, and some lymph nodes that are palpable. Is admitted to the hospital, undergoes a bone marrow biopsy that shows hemophagocytosis. And his labs are shown over to the left, to your right, sorry. He has anemia, hemoglobin is low. He's leukopenia, has thrombocytopenia, has elevated ferritin, elevated soluble IL-2 receptor. So with these features, he has 6 out of 8. And if you calculate his H score, it is 210. According to the app, anything above 169 is a very high probability. Based on that, he's diagnosed with HLH, treated with dexamethasone, and rapidly improves and is discharged from the hospital. Case closed. Because he was diagnosed with HLH, he responded to the treatment. They sent genetic testing, it came back negative, but you know, this could be secondary HLH. As the treatment is completed, the wean, the steroids, his fevers return, cytopenias return. So they start looking again, what's now? And they also find that he has a few copies of EBV. Oh, it must be the EBV that's causing him to have the HLH. So they repeat the treatment with dexamethasone, and this time they add rituximab. Those of you who are not in the hemonc world, rituximab is a monoclonal antibody that targets B cells because they contain CD20, which is the host of EBV in most of us. And so with that, again, he responds to this therapy. And because he has had recurrent episodes, it happened a 3rd time, they said, yeah, well, you need a bone marrow transplant for HLH. They identified an unrelated donor ready to start transplant, but his mother got cold feet. And his mother then reached out to me and said, hey, can you help? And so after our evaluation, this is the question. What do you call a fake noodle? Anybody? an impasta. We did a PET scan, and this is the patient's PET scan. It does not take a radiologist to tell you that this is highly, highly abnormal. There are lymph nodes spread all over. We biopsied one of them, classic Hodgkin lymphoma. And this is not an exception. Up until a few years ago, I would get one case every few months. Fortunately, the word has started to spread, so we're not seeing it as frequently. The other scary part is, at least in the adult world, physicians have become more confident in their ability to diagnose and treat HLH based on these criteria because they are simple and straightforward. So we're not hearing about them. Who reached out for this patient? It was not the physicians. It was the parent, okay? Another example, this one at our institute, 6-month-old with pallor splenomegaly. So the parents bring the child in because they think she looks pale. The pediatrician says, well, yes, she is pale, and she has an enlarged spleen. And the CBC shows severe anemia, leukopenia, thrombocytopenia. A bone marrow biopsy is done looking for leukemia. Turns out there's no malignancy. So, well, what else could it be? Well, it did show hemophagocytosis, and so they started going down the route of HLH. Yes, fibrinogen is low, triglycerides are high, soluble IL-2 receptor is high. You have 6 out of 8 criteria so far. They do a rapid whole exome sequencing, it's negative. Said, so maybe we shouldn't give etoposide. So they give dexamethasone, IVIG. I don't know why. Patient has no response. Surprisingly, one feature that is missing from here, fever. This child never had a fever, even though she looks and has these numbers that are so severe. It wasn't until we started thinking what else this could be. And the diagnosis was disseminated histoplasmosis. There are papers that say secondary HLH from histoplasmosis, baloney. It's just histoplasmosis. You treat the histoplasma, everything goes away. We have now had several such patients. This was one of the saddest ones. Again, a physician reached out, this time as a parent, not for the patient, but for their own child. A physician reached out and said, my 18-year-old who's previously healthy has HLH and is admitted to the hospital. Can you help? This is the history. Previously healthy 18-year-old started with fever and cough, then develops shortness of breath. X-ray shows bilateral lung infiltrates. Antibiotics, still not improving. Unfortunately, progresses, ends up on a ventilator. And at that point in the ICU, they start looking, well, why is she so sick? And they find that she has thrombocytopenia, a ferritin of very high, 10,000, elevated soluble IL-2 receptor, an H score that was 200, so consistent with HLH. They started dexamethasone and etoposide. It's been 2 weeks. She actually worsens and is now on ECMO. And that's when the father reached out to me. And so I started scratching my head that I don't know what HLH begins with cough. And the only thing disease I know of is a pneumonia. Have you done a bronchoscopy? They said, yes. So what did it show? Well, the bronchoscopy showed it was adenovirus. But what about why is this not adenovirus, disseminated adenovirus? Well, that's what it was. We checked a blood adenovirus PCR. It was more than 100 million copies per ml. At that point, that was the highest our lab had ever seen. Since this patient, we have had others who have been worse than this. Anyway, this patient was airlifted to our institute on ECMO. Imagine that, but they did it. At our center, we have availability of virus-specific T cells. So we had adenovirus-specific T cells. We gave that to her. Within 2 weeks, got the adenovirus down to 0. But unfortunately, her lungs were pretty badly damaged by then, and she did not survive. And a few weeks later, her mother died by suicide of the loss of her only child. So from one incorrect diagnosis, we had 2 deaths, both of which were likely preventable. And again, who reached out? It was the parent. And so what we have learned that all roads can lead to HLH if you utilize HLH 2004. These are all the diseases that I have seen being misdiagnosed as HLH, and the number just keeps getting longer and longer. There's not enough space on this map, but I left this one here. Name your disease, we can make it fit. And there are papers every week coming out describing a condition that leads to HLH. The definition of HLH being HLH 2004, okay? And so we tried to correct this misunderstanding. We first published a case series in 2018. That was, 7, 8 years ago now, followed by recommendations by the North American Consortium for Histiocytosis, known as NACHO. But all of these were completely outnumbered and outweighed by review articles, case reports that continue to reinforce the idea that 5 out of 8 criteria is the definition, or fulfilling the H score is the definition of HLH. Okay, so back in 2004, HLH was extremely rare. The advantage of these criteria is that they're simple, they're easy to understand, they rely on clinical features that are readily available at every hospital. You can measure CBC, ferritin, fibrinogen, triglycerides at every center. You don't need a specialized laboratory. And so it made HLH more accessible even to non-experts and raised the awareness of this condition. But the reality is, HLH is probably not as frequent as we think it is. So we have probably pushed the pendulum a little too far, overdiagnosing HLH. I gave you just a handful of examples, okay? Pediatric oncologists are rule followers. We will follow the protocol on no matter what, okay? And that has led us to now what I call this. This is the 11th commandment, that if you fulfill HLH 2004, you must have HLH, and the knee-jerk response is that you must give dexamethasone and etoposide. Now, and then came this dreaded cytokine storm with the coronavirus. It was on the front page of New York Times that ferritin cytopenias are the markers of cytokine storm that happens in COVID and many other conditions. And so what do you need in a storm? Just making sure everybody was still awake and listening. This is an umbrella drawn by my colleague, Scott Canna. And these are all the diseases that have cytokine storms associated with them. Not all cytokine storm is a pathologic one. And if you notice that the diseases named in these bubbles, the size of the bubble roughly corresponds to the incidence or probability of the condition. So the largest bubble is that of infection, with viral infections being the largest. Familial HLH is a tiny one, okay? I already gave you examples of histoplasma, leishmania, ehrlichia, influenza, COVID, you name it, Kawasaki's disease, malignancies, lupus. All of these conditions have cytokine storms. They will fulfill the criteria, but not all of them are HLH. And so somebody could ask that, well, aren't all these other diseases secondary HLH? But what is secondary HLH? It's just a description. It is not a diagnosis. I would say it's actually a lazy cop-out term, that you couldn't find the mutation, so we're just going to attach the label of secondary HLH. How does that help anybody? It does not help the patient for sure. If it makes you feel better, I think we need a change of plan. Because what it implies is that we don't know what this is. We're just going to attach the label because it fulfills these criteria that are non-specific. And as I mentioned already, majority of systemic inflammation is actually not maladaptive. It is often protective. In all these cases of infections where we blunted the inflammatory response, we made the infection worse because that inflammatory response was trying to protect us against the infection. If you do have maladaptive inflammation, which does happen, not all maladaptive inflammation is HLH. HLH is a very specific type, and there is still debate what that is. The only thing we know for sure is what is primary HLH. Everything else we are still learning and discovering. And so this is what happens if you have a patient with primary HLH on the left and you give dex and etoposide, you are putting out the fire. But if you have an underlying infection that was unrecognized, and now you give dex and etoposide, you're actually adding fuel to the fire, which is what happened in that poor child with adenovirus. If you have an unrecognized malignancy, which is what happened to the first patient, the 20-year-old, you give dexatoposide, you get temporary relief, giving you a false sense of security. But in reality, most of the cases, you're actually now selecting for a malignant clone that does not respond to chemotherapy, because almost all lymphomas will respond to dex and etoposide temporarily. Every patient will feel better with steroids for a few days, even if they have an infection. And we've seen that as well. The books tell us that don't give infection to patients, don't give steroids to patients with infection. That is true, but temporarily everybody feels better. And it makes us think that we've actually treated something. And so many leukemias, lymphomas, and inflammatory infections will temporarily respond to dex and etoposide. But until you treat the underlying condition, these will continue to recur. And just because they relapse does not mean it is HLH, does not mean that they need a bone marrow transplant. So as pediatricians, the disease that we want to care about is primary HLH. Okay, so if you can't use HLH 2004 criteria, how do we then recognize this entity of primary HLH? For that, we need to go back to some biology and what is our current understanding of the pathophysiology of primary HLH. So on this diagram, starting from the left, using viral infection as a prototype, you get a viral infection. There are these things called antigen presenting cells that will take up the virus and present pieces of it on a platter almost to the cytotoxic T cells, using CD8 T cells as an example. You can use NK cells, doesn't matter. In response to presentation of the antigen, the T cells become activated, they expand, and they do two things. They secrete inflammatory cytokines such as interferon gamma. And with interferon gamma, that results in activation of macrophages. But then they also, through direct cell-mediated toxicity, will get rid of the cell, the antigen-presenting cell that sometimes is the host of the virus, or they're trying to get rid of it, trying to say, yes, we have recognized this virus, we will take care of it, you can stop stimulating us. And so that results in two phenomena. One, the virus is cleared when you get rid of the host. And second, the immune response is terminated. And these T cells then shrink, become quietened down, and they are saved as memory T cells, the whole basis for vaccination, so that if you see the same virus again in the future, you are ready to act. What if something goes wrong with this process? And specifically, this second step, where the T cells kill or get rid of the antigen-presenting cell that is stimulating them. Well, these T cells still become activated. They are still secreting interferon gamma. They can no longer eliminate the antigen-presenting cell that is stimulating them. So the antigen-presenting cells continue to stimulate them. These T cells continue to expand, continue to secrete interferon gamma. That interferon gamma continues to activate macrophages, which then secrete more inflammatory cytokines. And now you're stuck in this vicious cycle that does not have an end. That's what happens in HLH. So let's take a look at this step. Well, how do T cells kill the target cell? What goes wrong there? So on the left in green is a cytotoxic T cell. On the right in orange is its target cell. There is a physical connection between the two cells, like the synapse of two nerve cells. We call it the immunologic synapse. In the immunologic synaptic space, the T cell will empty the contents of these granules, and the granules contain two molecules. One is called perforin, which perforates or makes a hole in the target cell. Through that hole, the second molecule called granzyme enters. Granzyme is enclosed in the vesicles or granules inside the T cells. If it is free inside the cytoplasm, it is extremely toxic and lethal. It will kill the cell. That is the intent. This is how T cells on the left kill the target cell on the right, by releasing perforin-containing granules. If you don't have perforin, you cannot perforate or kill the target cell. You may have all the perforin, but if you cannot move it, empty the granule in this immunologic synaptic space, you cannot kill the target cell. And so now we understand, on the top in this diagram is a T cell or NK cell. On the bottom is a target cell. In the middle is the immunologic space, immunologic synaptic space. These are the granules that contain perforin. There is a very sophisticated, orchestrated mechanism to move these granules from inside the cell to the immunologic synapse. A deficiency of any of these proteins underlined in red will keep those granules inside, locked in, and you can no longer kill the target cell. All of these genetic mutations are the cause of this one entity that we call primary HLH. Majority of them are autosomal recessive, which means you need two mutations on the two different alleles. There are two that are X-linked. And so this is another problem with the HLH 2004 criteria. These criteria stipulate that if you have a mutation that is known to cause HLH, your patient has HLH. Well, A single mutation makes you a carrier. It does not make you a person affected because these are all autosomal recessive or X-linked, okay? Now, majority of them are involved in that T cell signaling pathway, not all of them. We learned the biology of this over the last few years, and that came from the study of this one X-linked gene called XIAP. It has nothing to do with perforin or targeting the target cell. XIAP belongs to, or it regulates a new organelle that did not exist when, I'm sure it existed. We did not know that it existed when I was a resident, let alone when I was a medical student. And this is known as an inflammasome, which is present in all of our cells. This is how our cells, all of them, defend against invaders. An inflammasome, and XIAP is a gene or protein that keeps the inflammasome under check. In the absence of XIAP, the inflammasome is coming together, assembling and firing. And when the inflammasome fires, it releases tons and tons of cytokines, specifically this one called IL-18. That's the new name of this cytokine. The old name was interferon gamma releasing factor, because that is what IL-18 does. It stimulates the lymphocytes to release large amounts of interferon gamma. And if you were paying attention to what I have been blabbering about for the last few minutes, if you have lots of interferon gamma, you activate macrophages, you get HLH. So let's put this all information together to understand the pathogenesis of primary HLH. On the left, you have a cytotoxic defect. Either you don't have perforin or one of the signaling molecules called SAP, or you cannot move the lytic granules, or you have inflammasome deregulation. I use XIAP as the prototype example. We have now identified a few other mutations, all leading to deregulation of the inflammasome, releasing large amounts of IL-18. Or if you cannot kill the target cell, that leaves the lymphocytes in a persistently activated state. In that state, they release interferon gamma, which activates macrophages, and that's how you get HLH. This is the pathophysiology, or my current understanding of primary HLH, okay? Let's take one step further. I see some of my rheumatology colleagues in the room. They have their own form of HLH, which is called macrophage activation syndrome. Some of you may be familiar with this condition known as systemic onset juvenile idiopathic arthritis, SJI. Take any other autoimmune condition, but this is the most common one. For unknown reasons, in patients with SJIA, there is a sudden surge of IL-18. And when you have tons of IL-18, we think it comes from their intestinal epithelium. At least that is one source it may be coming from. There may be other sources. We don't understand. And what happens if you have tons of IL-18 circulating around? You activate lymphocytes, release interferon gamma, you get HLH, except this one is not caused by primary genetic mutations. It's caused by an acquired condition that happens in some patients with autoimmune diseases. So the name is MAS, or macrophage activation syndrome. You can call it HLH of rheumatologic disorders. It doesn't matter. So we add that to the pathophysiology. Over on the right side, where you have inflammasome deregulation, since it involves IL-18, we add MAS over on this side. So this is now expanding our understanding of primary HLH and a form of, if you will, secondary or acquired HLH, or MAS. Let's call it what it truly is, MAS. What else? Well, most of you have familiar with EBV, the virus that enters through the oral mucosa. From there goes into the tonsil. It infects the B lymphocytes in the tonsil, and those B cells then proliferate. Some of them are saved as a silent reservoir of memory B cells that have EBV in them. I still don't understand the evolutionary basis. Why does that happen? It makes up for job security for those of us because you get PTLD in some patients, but that's not why it should exist. These proliferating B cells then enter the blood circulation and they elicit a cytotoxic response. A normal mini self-contained HLH. Those of you who have suffered from mono, you feel lousy, miserable. You get fever, splenomegaly, cytopenia. It's because tons and tons of interferon gamma circulating. Eventually, those T cells bring the proliferating B cells under control. EBV is brought under control. It's a self-contained HLH. Infection resolves. You feel better. There are certain immune deficiencies affecting T cells specifically in their ability to control EBV-infected B cells. We have now identified several of them, and those are listed on the left here. And so in this situation, and you can have this in acquired immune defects as well, such as HIV or immunosuppressive chemotherapy, either during malignancy or bone marrow transplant. Those of us in the transplant world are quite familiar with this EBV lymphoproliferative disorder that happens when you have a defective immune system. You have EBV containing B cells that are proliferating. In response, you get a T cell activation, but those T cells cannot kill the B cells, so they remain in a persistently activated state, giving rise to HLH. The treatment for these situations is you need to get rid of those B cells that are infected with EBV. And the quickest way to do that is with rituximab, sometimes with chemotherapy. When you do that, the T cells quieten down. And nowadays, we have EBV-specific T cells as well for this condition. But then, fascinatingly, in some people, EBV infects the T or NK cells. In most of us, it is the B cells, but this is more common in people whose ethnicity is Pan-American, that is native to North, Central, South America, or people who hail from Eastern Asian countries, China, Japan, Thailand, Mongolia, Singapore, you name it. In these individuals, EBV will enter the T and NK cells, in most of them giving rise to a temporary EBV like mono-like illness, but sometimes it runs rampant out of control, giving rise to an acute EBV-mediated lymphoproliferation, which looks exactly like a lymphoma. It's a T or NK lymphoma that fulfills all of the features of HLH. None of these people have genetic defects, at least none that any of us have ever found. The way you differentiate this from regular mono is you actually have to sort the lymphocytes and do a quantitative PCR to see which cell is the host of the EBV. This is now available as a clinical test from our laboratory. But this often gets labeled as EBV HLH because it fulfills the HLH criteria. Actually, it's a lymphoproliferative disease, a lymphoma, okay? The correct terminology, I would say, is EBV lymphoproliferative disease. Secondary HLH, sure, you can use that label, but it is just simply wrong. And if you give dexamethasone to these patients, you will get, at best, a partial transient response. Majority of them will continue to recur because this is not HLH, it's a lymphoma. So the treatment has to be what we historically had been using was lymphoma chemotherapy followed by allogeneic transplant. For the last 2 years, we have discovered this novel therapy, PD-1 inhibitor, that has eliminated the need for transplant altogether. We can talk about that separately. Okay? So with all this new knowledge that I have shared with you, we now have new assays that help us fine-tune or make our diagnosis a little more precise. So if you had been listening, interferon gamma is the key cytokine in HLH. We cannot measure interferon gamma directly. Technically, it's difficult, but you can measure its surrogate called CXCL9. We can measure activation of T cells using this marker called soluble IL-2 receptor. I just told you that these are non-specific, yes, but they have very high negative predictive value. That means if they are normal, you can take HLH off your table. It cannot be HLH without T cell activation. We all know that there are now so many genes, but they all do one or two different things. There are now flow-based assays for almost all of the primary HLH genes. And the advantages of the flow-based assays is that, one, they're rapid, they are quantitative, and they are reliable. Okay, and they have very high specificity. And you can now also measure IL-18. So with all these assays, you can now differentiate whether you're dealing with primary HLH, macrophage activation syndrome, EBV, or none of the above. Then you need to keep looking for a hidden malignancy or an infection. So here's one example of what a flow cytometry assay looks like. On the top is a normal control individual. What you're looking at is the red line in NK cells. 100% of them have presence of perforin. A small number of T cells at rest have perforin. On the bottom is a patient who we suspected had primary HLH. And with this one assay, not only have we confirmed it is HLH, we have identified the gene that is responsible, complete absence of perforin with one test. Okay, we have identical assays for the other two X-linked genetic mutations, SAP and XIAP. And then this assay called CD107A measures the movement of the lytic granules from inside the cell to the immunologic synaptic space. I will not go over the details, but just showing you an example again. On the top is an individual who is at rest. The T cells don't have any CD107A once you stimulate them. A lot of them do. This is an individual who we later on turned out to identify the genetic mutation, but there's no CD107A detectable on the cell surface. So with the advantage of the flow assays is that you can identify the function of several genes with CD107A. So if CD107A is normal, all these genes are working normally. You've made the diagnosis of not HLH. If it is abnormal, it's one of these genes. You can focus what to focus on. So between all of these flow assays, you can capture almost all of primary HLH. You still need genetic testing to confirm it, but as I mentioned, primary HLH is autosomal recessive, so you must have 2 mutations. We currently don't know all the mutations, so many times you get back something known as a VUS, and then you're scratching your heads, what the heck do we do with that? That's where the flow assay come in handy. If the flow assay is normal, it is truly a VUS. If the flow assay is abnormal, that's not a VUS, that's a pathologic mutation. Unfortunately, the results still take much longer. At our institution, it takes 4 to 6 weeks. There are some centers that are giving much rapid turnaround. There are labs in California, Machion Diagnostics, that gives you a much rapid turnaround, but it's still not, the flow assays are still much faster in our experience. If you're going to use a gene panel, don't use the HLA gene panel. It's too narrow. You need something that is a lot more comprehensive because there are many immune disorders that can manifest HLH. Instead of looking for HLA gene panel, look for a primary immune deficiency. But again, there are limitations because there are mutations in the non-coding regions that are not covered by any of these gene panels, which is why you still need the flow assays. Okay, so if you put all this information together, let's not call the HLH 2004 as a diagnostic criteria, recognize the limitations of both, whether you use HLH 2004 or H-score. You can still utilize them to question, could this patient have HLH? Yes, they might, but fulfilling the criteria is definitely not sufficient to diagnose it, okay? Instead of using those criteria, we have created a new algorithm that is available freely on our website. You can go to cincinnatichildrens.org, search the word HLH, or scan this QR code. Or for all of you trainees in the room, I have a gift. If you were to stand up and ask a question, I have a pen, and hidden inside this pen is this diagnostic algorithm. But you have to talk to me in order to get this, okay? Either during this presentation or after, I don't care. So instead of asking the question, does this patient have HLH? Look for what is the driving inflammatory signal? What is causing this child to be inflamed or patient? And then ask the next question, will immune suppression be helpful or will it be harmful? Those are the 2 questions you need to ask, okay? Sometimes, or often, things are clear as mud. I just got done telling you that disseminated adenovirus histoplasma, you don't need steroids or immune suppression. If you have EBV causing HLH, whether it is the B cell kind or the T cell kind, some immune suppression, yes, is temporarily helpful. And it is indicated. But then there are some situations, a child is septic in the ICU, getting worse, organ dysfunction, bacterial sepsis, influenza. Should you use steroids? Sometimes yes, sometimes no. This is where things get complicated. And sometimes there's no straightforward answer. There are newer immune modulatory drugs becoming available that leave the immune system intact, but still prevent or block a cytokine that is causing the problem. So that is where I think the future lies. And of course, as I mentioned earlier already, when we diagnose adults with HLH, we are forcing a square peg into a round hole. In most adults, HLH is actually a lymphoma until proven otherwise, because it is a process. Even in children, infections, leukemia, lymphoma are more common than primary HLH. So this is a hand-drawn line diagram by me, just giving an example of primary HLH is more likely to happen in an infant. Lymphoma is more likely as you get older. Infections can manifest the feature of HLH at any age, okay? I'm going to skip. Treatment, yes. Dexitopicide are for primary HLH. It is not a strict protocol that you must follow. You can use it as Tylenol for headache. If you have a headache, take Tylenol. If you don't need to. So dexitopicide, use it to bring the inflammation under control. Once you have it under control, start weaning it. You don't have to follow the 8-week protocol. And yes, bone marrow transplant is reserved for primary HLH. I have been mentioning interferon gamma. There's a newer drug that is available that blocks interferon gamma. It's a monoclonal antibody called emapalumab, and it blocks interferon gamma and its signaling. A multi-center clinical trial was carried out that was published in the New England Journal of Medicine. Now it's been 6 years since the drug was approved. I will skip over that and summarize that HLH is an inflammatory process, not a specific disease. Recognize that HLH 2004 and H-score are not sufficient to definitively diagnose HLH. Please recognize and remember that there are newer assays like the flow-based cytometry assays. Always think of malignancy and infection. Newer treatments like emapalumab are emerging. When in doubt, please reach out to us. We are always looking to learn from our colleagues to see what other things look like HLH. So that's our email address. I want to thank all the information that I shared with you. I learned from all of my colleagues who are shown in this picture listed on here. And before I end, I told you there are 14 syllables in hemophagocytic lymphohistiocytosis, and that's important. And I need to take a gulp of water for that. Warm coffee. And that's because if you ask a child and you tell them hemophagocytic lymphohistiocytosis, what do they think of? Mary Poppins, anybody? Supercalifragilisticexpialidocious. It has 14 syllables. So I wrote a song that rhymes with supercalifragilisticexpialidocious. And sorry, you can plug your ears or leave the room. I'm going to sing it for you. So here goes. Hey, hemophagocytic lymphohistiocytosis. It's not one disease and rarer than cancer or viral sepsis. Simple score criteria lead to wrong diagnosis. Hemophagocytic lymphohistiocytosis. Hum diddle high. Hum diddle high. Now in the deep, dark voice of Dick Van Dyke. When the child is hot and has liver inflammation with blood counts low, think HLH, but also cancer and infection. If low fibrinogen, high SIL2R and ferritin, then flow for CD107A and perforin. And in boys, also flow for SAP and XIAP. Get a PET scan biopsy, EBV and IL-18. When in doubt, phone a friend. Don't be getting euacycosis, hemophagocytic lymphohistiocytosis. Thank you. And please remember to scan the QR code to get credit for.
Not credit, sir.
Oh, for the survey. Thank you. Yes. And now, whoever wants a pen, ask a question. Those of you online, if you ask a question, I will make sure I leave a pen here for you with some of your friends. Get it from them.
How do you use IL-18 in practice?
So the question from Dr. Shah is, how do we use IL-18? So if it's an infant and there's a family history, it's obvious. If it's a toddler, older child, if there's a history of a skin rash or joint pain, then we suspect this is more likely to be MAS. But many times we just don't know. So we now add IL-18 to our battery of tests that we send in every patient who we suspect has either HLH or MAS. Even in primary HLH, IL-18 will be slightly high, but slightly. If it is sky high, and this is something you have to get familiar with over time, recognizing what is slightly high, what is sky high. So in IL-18, if it's less than 5,000, it's not going to be MAS. If it is more than 50,000 or more than 20,000, it is almost guaranteed to be either XIAP, either an inflammasome disorder or MAS. It's one of those two. So if it's a female child or a female teenager and has IL-18 of more than 100,000, it's more likely MAS. But, you know, every now and then we do get surprised. So that's how we utilize it. That's how I utilize it. Yes.
In an EBV-driven lymphoproliferation, when do you decide to sort and look for like T cells?
Yeah.
If there is a substance C response, or
So that, excellent question. When do you decide if you have a patient with EBV, HLH, LPD? Is it in the B cells or the T cells? If the child is very sick with multi-organ failure, most likely it is more likely to be in the T cells. If it is an individual with East Asian or Native American or Hispanic ethnicity, my suspicion is much higher. But lately we have seen Caucasians white as they can be, have T-cell disease. So there are a couple ways. You can either give rituximab and measure the EBV. If you've eliminated the B cells, one dose of rituximab is all you need to get rid of the circulating B cells, and your EBV count is still high. You've proven that it's not in the B cells. Or you could send a sorted PCR. Usually you'll get an answer in 24 hours. You have to call the lab and tell them, hey, we need it. So they'll save a spot on a sorter for you the next day. But usually they'll run it very quickly. And that is one of the fastest resulting assays.
And you sort on the blood.
We sort on the peripheral blood, not on the bone marrow. It has to be peripheral blood, which means that if you've given lots of steroids and etoposide and there are no lymphocytes or the ALC is less than 500, you're not going to get your result. So you need lymphocytes in order to sort them. If you've given rituximab, and usually the answer is you have your answer right there. Natasha. And then Maui. Sorry, Natasha, go ahead.
We're talking for CNS involvement.
Yeah.
Because, are the babies
Yep.
to be sedated for the MRI.
Right.
And they've already been sedated for a biopsy.
Right. So CNS involvement in primary HLH. The whole thing, it started, most of the people, when they started thinking about HLH, we were looking at it as leukemia, ALL, because that's the disease we are most familiar with. And in children with ALL, they will, many times, they will have CNS involvement. So we have to do a lumbar puncture. In HLH, at presentation, they are thrombocytopenic, they are coagulopathic. You cannot do an LP in that situation. Do you need an MRI? Maybe at some point. It is not urgent. And the reason for that is dexamethasone crosses the blood-brain barrier. If there is HLH, you are taking care of it. Etoposide, eliminating the T cells, gets rid of them from the CNS as well. So in most children with primary HLH nowadays, we actually never have to use, it's very, very rare that we have had to use intrathecal chemotherapy. So at some point, yes, you need to do an MRI to make sure that there are no residual effects. And especially if you're going to take the child to a bone marrow transplant, if it's primary HLH, you most likely will. You need to know the baseline status of their brain, because if somebody does an MRI in the future and they find something abnormal, then you don't know what you're dealing with. So it is not an emergency. If the child has CNS symptoms, then of course you will want to intervene. But in most children, if you start with dexamethasone and etoposide, if there is HLH cells, if there are these T cells and macrophages in the CSF surrounding the brain, you are treating them with that. So you can wait to do an MRI or an LP at some point in the future. It does not have to be done right away.
Dr. Walsh and Dr. Jane, Dr. Williams have their
Hands up. Okay.
They can unmute.
Okay. If you want to unmute, we would like to hear from you. While they're doing that, Maui, please.
So we have nivolumab, as you said, for the EBV lymphoproliferative disorders, but with insurance costs and all that, if you have to do CHOP,
Yes.
how many cycles?
Yeah. So if you're dealing with the T or NK lymphoproliferative disease and you can't get nivolumab, or you have to start with CHOP, as many as you need just to get the disease under control and either go to nivolumab or bone marrow transplant. I will tell you, we have not transplanted a patient now for the last 2 years, and we have treated now about 12 patients with nivolumab, and every patient with the T-cell lymphoproliferation has responded and has been cured. So we are not doing transplants anymore. We have 2 patients with NK cell disease, one of whom developed severe cardiomyopathy that we think may have been a side effect of nivolumab. So that patient, we stopped nivolumab after 1 cycle and took him to transplant. The second patient with NK disease has become completely asymptomatic. The EBV viremia persists, but she is completely healthy and normal. So we are just watching. It's been 1.5 years. So our experience, we are writing the paper. The abstract was presented at the BMT meeting in Hawaii this year. So we have not had to use CHOP in anybody. We can get nivolumab, it works. But if you can't get it, I would say 1 or 2 cycles as you're preparing for transplant. CHOP is not going to be your curative answer. You will still need to do either transplant or nivolumab after that, or pembrolizumab. Take your pick, doesn't matter which one you use.
Is it indefinite or?
No, we do 4 cycles of nivolumab and then they're cured. That's it. That's all we have to do. Yes,
You had to use or at any point the CTLs? And any of-
so CTLs or virus-specific T cells for the T or NK lymphoproliferative disease, for whatever reason, they don't work. So we tried many years ago, and that has been the experience of our colleagues at Children's National, that the virus-specific T cells that have been trained to fight EBV will get rid of EBV in the B cells, but not in the T cells. And I think it's because, you know, it's called fratricide. The T cell will not kill its own brother T cell. So perhaps that's what it is. We still don't understand the pathophysiology of how does EBV even enter T cells. T cells don't have CD21, which is the receptor for EBV. Somehow it gets in, somehow sets up a lymphoma. Somehow these cells can evade destruction by other T cells. But when you activate the T cells with nivolumab, now all of a sudden they become susceptible to them. So my understanding rudimentary currently is that EBV actually, when it enters the T cells, upregulates PD-L1, which blunts the virus-specific T cells from killing it, which is why when you give nivolumab, you can have all the PD-L1 you want. It's been blocked. Now the T cells can kill the other T cells. That's my current understanding. I think someone will do some more research and figure it out. Yes, sir.
Position anakinra and nivolumab
Yeah.
in non-primary HLH.
In non-primary HLH, the question is, where do we position imapalumab and anakinra? Anakinra is much easier to answer because amongst, so there are these newer drugs emerging that block cytokines, and anakinra blocks IL-1, specifically IL-1 beta. And if you remember, I showed you activated macrophages secrete IL-1. Anakinra is one of the safest, easiest to use cytokine blockers because it has a very short half-life. It can be turned off instantly. It does not affect the residual cells. So in non-primary HLH, especially in the ICU, if you have a patient with sepsis, viral sepsis, bacterial sepsis, and they have multi-organ failure dysfunction, despite all the antimicrobial drugs that you have used, that's where I introduce anakinra. Of course, in patients with the after CAR T cells, if they get this entity called CRS, we start with tocilizumab. After that, if they're still getting inflammation and the ferritin starts to rise much higher than it was, that is a marker that the macrophages are being activated. Surprisingly, anakinra works beautifully in that situation. And if you don't know what you're dealing with, when in doubt, anakinra can be used if the ferritin is high. If the ferritin is normal, anakinra is not going to be helpful. That's been our experience. For imapalumab, it's specifically for interferon gamma. Yes, the label says it is for primary HLH, but in reality, it's actually for interferon gamma. So if you have a patient in whom you find very high levels of CXCL9, as long as you know there is no active infections such as histoplasma, Ehrlichia, tuberculosis, you can use imapalumab as a temporizing measure until you figure out what this is. We recently had a patient with active TB who developed DRESS syndrome. Everybody know what DRESS is? Drug reaction eosinophilia with systemic symptoms. Severe DRESS that led that patient to develop respiratory failure, circulatory failure, renal failure, and hepatic failure. Every organ shut down. She was on a ventilator, on dialysis, and on Mars. And thought, oh my God, this child is going to die. And we got a CXCL9. It was more than what our lab could measure. This patient has TB. What do we do in this situation? We gave 1 dose of imapalumab. 24 hours later, she got extubated. Dialysis was turned off. We only gave 1 dose, completely against the books. That's because she had DRESS syndrome and we were able to turn it off. Eventually, it turns out that it was the first TB drugs, then they introduced alternative TB drugs, and then brought in some systemic steroids and the combination. Sometimes you have to play the game of doing both simultaneously. So sometimes you need to do both, fight the infection and the inflammation at the same time. So that's how we would use it.
Okay. This is John Hartley. If you can hear me, we got a good
Yes, sir.
question in the chat. have you ever seen imapalumab useful in sepsis? I know there's a study underway looking at this, but my understanding of sepsis tells me it's unlikely to be beneficial.
Yeah, I don't have any firsthand experience of using imapalumab in sepsis. I would be very wary of it unless you know for sure that, unless you have CXCL9, which is significantly elevated, and you have identified the pathogen. But I think, like you said, I think we need the study, we need the data to know for sure.
Okay, and then another question, this is just as a hospitalist. A lot of the time when we start thinking about HLH when we've got a kid with fevers, there's been on antibiotics for several days, there's no known bacterial infection that we're treating, and they're still having fevers. And that's when we, get our, ID and rheumatology and hemat colleagues all involved. And a lot of times the response is, well, they're not getting sicker very fast, so it's probably not HLH. Do you agree with that, or does sometimes HLH smolder before it blazes into a flame?
Yeah, unfortunately, there is no one set defined pattern that tells you this is and this isn't HLH. So my response to your simple question is it's complicated. It's not as simple. So, for all the residents in the room, when should you do an LP? When you think of it. So it is absolutely true. I mean, if you think this child needs an LP, you should do an LP. It's not that difficult. It's not that dangerous. Yes, it's a needle in the back, but if you think this child might have HLH, you should do the investigations. Which ones should you do? I leave that up to the local institution. The lowest hanging fruit will be you can look for other diseases that manifest the features of HLH. But if you want to do the lowest hanging fruit, if you get a soluble IL-2 receptor and it's normal, then you can say for sure that this is not HLH. But please measure it before you give the first dose of steroids. And so the answer, I don't think, can be, does this patient have HLH or not? I think the question should always go back to, why is this child inflamed? And will immune suppression hurt or benefit in this situation? That should be the question. And in the differential diagnoses of inflammatory disorders include infections, malignancies, primary HLH, all of that. And there is no one set pattern. So I'm afraid I have been burned both ways when I thought there's no way this child is HLH, and lo and behold, they did. And another case where I knew for sure this will be primary HLH turned out not to be.
Okay.
Dr. Shah?
Task force in your hospital?
Yeah, yes, actually we do. Correct. Yes. So we have what we call the HLH response team. And it's the combined there's 3 of us in BMT who do this, 2 of our colleagues from rheumatology, 1 from ICU and 1 from infectious disease. And we are the ones who talk about every new suspected HLH, and we exchange phone calls, emails, texts. We don't always, all of us, see the patient, but we talk about every patient whenever we can. So, and that is what we recommend, that every institution should establish. And again, I'm not going to dictate what you should do, but we recommend that this may be one way of doing it, is identify point people who will learn as much as possible about HLH, establish contacts with other institutions, experts who know which lab to send when to which institution, to which center, so that on a Friday evening when that patient arrives and you're scratching your head, you don't have to think from start, what should we do? Have all the information available. And of course, we are always willing and wanting to hear from everybody. So at least I can say that for myself. Reach out to us if we can be of any help.